Hi, everyone. My name is Rebecca Quinn, and I'm a first-year resident at Access Health Teaching Health Center in Beckley, West Virginia. My presentation today is a very unique case of a 16-year-old male who suffered a left hemispheric cerebral vascular accident. This patient presented to the emergency department for a 2-day history of right-sided face, arm, and leg weakness. The patient's grandmother was the primary historian who reported that he had multiple falls in the last week, which was unusual for him as he was normally steady on his feet. She denied any similar prior episode. This patient's medical history includes Down syndrome and autism spectrum disorder. He has never had any surgeries and only takes loratadine 10 milligrams once daily. He has no known drug allergies. Physical exam was notable for the following. He was found to be hypertensive with a blood pressure of 158/77, a temperature of 99.5, and a BMI of 30.59. Neuroexam revealed extraocular muscles were impaired toward the right. Facial sensation was absent on the right forehead and decreased sensation over his right cheek and chin. The patient had unequal facial expressions and was unable to raise his right eyebrow. He had an unequal smile with the right side that remained unmoved. He had decreased shoulder shrug on the right. His tongue protruded midline, but he was unable to deviate his tongue towards the right. Strength was decreased at 4 out of 5 in his right upper extremity. Head CT revealed bilateral basal ganglia calcifications, and brain MRI revealed a large area of restricted diffusion in the left basal ganglia. The patient's right facial palsy and right hemiparesis were not able to be fully explained by the MRI lesions. Labs revealed the patient had hypothyroidism and hypertriglyceridemia. Weakness improved and the patient was discharged to home 2 days later on aspirin. Further outpatient testing did reveal heterozygous factor V Leiden mutation. The first picture here on the poster shows a brain MRI of a patient with an area of restricted diffusion in the left basal ganglia suggestive of an acute infarct. Below this, on the left, is a head CT of a patient with Down syndrome with bilateral basal ganglia calcification. The right image is a head CT of a 46-year-old Down syndrome patient with basal ganglia calcifications. This patient did have several risk factors for stroke despite his young age. Some modifiable factors included obesity, hypertension, hypertriglyceridemia. One risk factor that he could not control was his genetic makeup. The factor V Leiden mutation is considered the most common genetic disorder that can lead to blood clots. It is associated with ischemic stroke in children, but not in adults, and this association is still uncertain. Patients with a heterozygous mutation have only a 5% chance of developing a blood clot by age 65. What makes this case stand out is not only the rarity of a stroke in an adolescent, but also that this patient has Down syndrome and autism. A brain pathway that controls movement is altered in people with autism. This pathway courses through the basal ganglia, which are tiny clusters of neurons in the central area of the brain. These clusters connect the cortex that controls reasoning and social skills, as well as connects the cerebellum, which coordinates movement. Both regions are implicated in autism. Neuroimaging studies show that intracranial calcifications most often show up in the basal ganglia, particularly in the globus pallidus. Down syndrome is not known as a common cause of these calcifications, even though it is a common finding on neuroimaging and pediatric neurology practice. Occasionally, this can cause neurosymptoms, but asymptomatic cases are by far the norm. The pathogenesis of calcification in Down syndrome is not well understood. Down syndrome is associated with a high risk of stroke in all ages. These patients have a greater tendency for the buildup of amyloid plaques in their brains and therefore appear to be more susceptible to strokes for this reason. These strokes usually occur later in life, however, which makes this patient an outlier for being only 16 years old. Was this patient somehow predisposed to having a stroke in this particular region of the brain given his medical history? As studies have shown, this region is often compromised in those conditions. This patient also recovered very well from the stroke, and this raises the question of why. Being of young age was likely helpful in the healing process. However, could it also be that his brain, particularly in the basal ganglia region where the stroke occurred, was already compensating in ways that could possibly aid in its own healing process? The short answer is more research is needed to better assess these outcomes. I just wanted to say thank you to everyone who made this presentation possible, and I hope you all enjoyed listening. If you have any questions, please feel free to ask them in the comments below.